Hello, this presentation will be on sulfonamides and trimethoprim. Sulfonamides and trimethoprim are broad-spectrum antibiotics. They are closely related and they suppress bacterial growth through um, the suppression of folic acid production. Sulfonamides were the first drugs available for systemic treatment of bacterial infections. But of course, we have many other classifications and drugs to use that are more effective and less toxic. They inhibit bacterial growth through uh, not allowing the cells to manufacture folate. And since we have more effective drugs for other infections, it is primarily used now for UTIs. Adverse reactions to sulfonamides include hypersensitivity reactions such as Stevens-Johnson syndrome, which is a widespread rash including the mucous membranes that, if left untreated, has a up to 25% mortality rate. Hematologic effects can include hemolytic anemia, which is not common, is rare. Kernicterus, which is bilirubin on the brain in the newborn, and renal damage from crystal formation. Drug interactions include metabolic-related interactions such as increasing the effects of warfarin, dilantin, and sulfonylurea diabetic medications, and also cross-sensitivities to the loop and thiazide diuretics, and also to the sulfonylurea agents used in diabetes. There are topical as well as systemic forms of sulfonamides, and those we aren't using many of the topical treatments anymore, except for here the what we would commonly call Silvadene and the mifenide. We also use a ophthalmic preparation, the Blethin, for conjunctivitis. Um, but here, when we're talking about the topicals, they're usually used to suppress colonization in patients with second and third degree burns, and it's very effective. Um, for the mifenide, the application is painful where it is not with the Silvadene cream. Both have the potential for systemic absorption, but with the mifenide, you have to watch for acid-base um, imbalances and acidosis. With the trimethoprim, it inhibits the synthesis of DNA, RNA, and some proteins within the bacteria. Its main uses are for acute and uncomplicated UTIs. It has the same adverse effects that we found in the sulfonamides, and you must remember it cannot be used in pregnancy or lactation. So when we have this combination here of the trimethoprim and the sulfamethoxazole, it is used to stop folic acid synthesis, and they work better together than alone. Therapeutic uses can include UTIs, otitis media, bronchitis, pneumonias, and some GI infections. One thing to remember with the UTIs, you should always do, if possible, a culture and sensitivity to make sure that it is effective against the organism that's causing the UTI, especially if you're in a setting where you have a limited amount of options for the patient. In that case, you don't want to use something that isn't going to work at all, because that can give you justification to petition for use of another medication. When you start prescribing, you'll have your formularies of what is covered, And sometimes you can get other medications covered if you can prove that the one that is on the formulary will not be effective for this patient. And of course, the culture CNS would give you proof of that. Adverse effects include GI, nausea and vomiting, the rash, any kind of rash, and especially anything that may look like Steven Johnson's. I always tell patients, if you develop a rash, to please come into the office and let me see it right away. Don't wait a few days or wait to see if it goes away first. And now we'll go on to questions. Question 1, patient who takes warfarin is prescribed sulfadiazine. When teaching the patient about this drug, what should you include? And the correct answer is C, to avoid prolonged exposure to sunlight. Because it's Question 2, patient is taking a sulfonamide, develops Steven Johnson's. What are you looking for with the patient? And the answer would be D, a widespread skin lesion. And that is it for this presentation today. Thank you. Hello, this presentation is on miscellaneous antibacterial drugs. The first classification is fluoroquinolones. They are broad-spectrum antibiotics with multiple applications. What they do is disrupt the DNA replication and cell division, and they can be administered orally or via IV. Side effects are generally mild, but there is a risk of tendon rupture, which usually affects the Achilles tendon. So you want to avoid use in patients younger than 18, but there is a risk to all patients, especially those over 60, those on corticosteroids, and those that have undergone kidney, heart, or lung transplantation, because of course they're usually on the glucocorticoids. So under the fluoroquinolones, you have Cipro or ciprofloxacin. It is a broad-spectrum antibiotic that covers gram-negative and some gram-positive. It works by inhibiting DNA replication. It's used for many different infections. It is a drug of choice for anthrax, and that's important with our concerns now with bioterrorism. But we use it and have used it for years for respiratory infections, for UTIs, for GI, bone, joints, skin, and soft tissue infections. There is some bacterial resistance with the use of Cipro to certain organisms that are listed here. So again, especially if it's a UTI, you want to do a culture in CNS to make sure what you're treating and if the Cipro would still be effective. What are some adverse effects of using Cipro? Besides the tendon rupture, you can have GI, nausea, vomiting. You can have systemic central nervous system effects of dizziness, headache, phototoxicity. You can have candida from just being on an antibiotic. There is an increased risk of C. difficile with the use of Cipro. And in older adults, you have to watch for confusion, visual disturbances, psychosis, and there can even be a chance of myasthenia gravis. You have to watch for food and drug interactions with antacids, with iron salts, zinc salts, with dairy products, with theophylline, warfarin. There are several other fluoroquinolones that are used for infections. You have ofloxacin, moxifloxacin, norfloxacin, levofloxacin, gemifloxacin, which is one of the newer ones. Uh, One nice thing about some of these, like your levofloxacin, you only have to take it once a day for 3 days, as opposed to taking a 5, 7, or 10-day course for many infections. The next drug here is the metronidazole or Flagyl. It is bactericidal. We use it for the protozoal infections, by infections caused by anaerobes. It is used as part of the regime for a 3 or 4 drug treatment for H. pylori. Adverse effects, you can have neurotoxicity. There can be allergies to the meds and superinfections caused. Other antibacterial drugs, you have rifampin, which is a broad-spectrum antibacterial used for TB. It can be used for some meningitis, but not as the monotherapy. It can also be used as prophylaxis for meningitis due to H. flu. And rifaximin is a PO form of rifampin, which is used for traveler's diarrhea. A newer indication is for encephalopathy in patients with chronic liver disease. You also have bacitracin, which is a topical agent that's used frequently. You can get that in an OTC preparation for topical bacterial infections. And we also have the polymyxin B, which is a topical treatment for ears, eyes, and skin. It is not used systemically due to its toxicity risk. I don't like this one either.